I hope you enjoyed the coffee. I think we're ready for the next session, the scientific session 4 on neuromodulation. I'm Álvaro Pascual-Leone, and I think we have a great session with different speakers touching on different methods of neuromodulation. You'll hear from Christopher Butler about temporal interference stimulation. Guglielmo Foffani will talk about static magnetic stimulation, and Giacomo Koch about circuitry-guided transcranial magnetic stimulation. And what I hope to do is to give you a little bit of an overview of these techniques with a focus on transcranial alternating current stimulation, so that at least you've heard about the different methods. So with that intro, let me maybe get started. Sorry, here we go. So I'm going to talk about non-invasive neuromodulation as a means to modulate, to modify spatio-temporal signatures that map onto disability. I'll try to tell you what I mean with that, but before getting going, let me give you my disclosures. They are here. I don't think any of them are directly relevant, at least to my talk. There is a bit of a conflict of interest with Chris, because I'm a co-founder of a company that does TI solutions, but obviously it's not. I wish it was a successful company. It's not, but it's starting. Anyway, we're going to talk about non-invasive brain stimulation, and there are many ways to do non-invasive brain stimulation, and I'm sure you'll hear about this from the other speakers also. One can apply electric stimulation directly, electromagnetic stimulation, magnetic stimulation. One can use light in a variety of different forms, ultrasound in a variety of different forms, even radiation therapy at low grade, even multisensory stimulation. We're going to hear particularly about transcranial current stimulation in the form of TI stimulation, the last one there, and I'll tell you a little bit about the others. And then we'll hear about static magnetic stimulation and about transcranial magnetic stimulation. But perhaps one way to think about this is an overarching theme rather than focusing on the differences between them, which are many, but there is a common theme there. These are all tools. They're not treatments per se. They're just tools that allow you to perturb the brain. And I'll try to give you some examples of that. In perturbing the brain, there is a possibility of gaining fundamental insights about brain function in our setting, in this context of dementia and specifically Alzheimer's disease, and in doing so at the same time helping patients. We'll try to give you an overview of that. Part of what we can elicit insights in relates to brain circuits, both the mechanisms of plasticity, the connectivities, their patterns of oscillations, the topographic distribution, but also the degree of hyper or desynchrony. So one way to think about this is that we have a certain brain structure, and in health that gives rise to a certain pattern of brain activity, which we can characterize in snapshots of different moments as spatio-temporal signatures that map onto different emotions, thoughts, behavior. Think of it as the proximal correlate of behavior, cognition, emotions, as the essentially product, these spatio-temporal signatures as product of the functional unit of the brain being not the neurons themselves, but ensembles of neurons. In the setting of disease, including Alzheimer's disease, there is an alteration either of structure or of function, the net result of which ends up being probably the same because of the interaction between them. And it gives rise to changes in spatio-temporal signatures, alterations of spatio-temporal signatures, which become the proximal correlate of symptoms or disabilities, of specific symptoms or disabilities. The idea then with brain stimulation, and in this context specifically with non-invasive brain stimulation, is that going beyond the definition of brain-related disabilities ultimately as alterations of brain circuits, as circuitopathies, we can, with these tools, provide a controlled perturbation of the brain. And in doing so, we can explore the causal relationship to the symptoms. We can even explore the possibility of an upstream effect on the pathology itself. And I'd like to show you a little bit of that approach. Now, Recep Özdemir has done a number of studies looking at the response of different brains, healthy or patients with Alzheimer's disease or mild cognitive impairment and dementia, in response to different perturbations. In this case, with transcranial magnetic stimulation, and recording the responses with EEG. And you can characterize the local response, and you can characterize the distributed reaction to that different perturbation depending on the location. The interesting feature about this is that there is a fair amount of variability between different individuals in response to these perturbations, but there is a real fingerprint of the response of any one personal brain in how it relates, in how it reacts to at least 4 perturbations. So if you apply 4 or 5, in this case, perturbations, you can see in the right upper corner, there is a very, very high, true, reliable signature. You can identify an individual brain by the response. The appeal of that is that it allows to track the individual over time and detect deviations of the pattern of response of that individual with a high degree of precision, with a very early detection. The cause for that deviation could be whatever. It could be a medication or it could be a pathology, but it allows a very early detection and a possibility of intervention. For example, we can, in this case, Mark Eldaev, do a perturbation to the angular gyrus and get a different pattern of response in those who are young and those who are elders, as shown by Kilian Avellaneda using fMRI, based on the connection across various synapses to the anterior frontal, mesial frontal areas. What is interesting is that if you look at the individual level of responses, not at group responses, then you can see that there are individuals who, despite being old, respond in a very similar way to the young, with a lot of forward connectivity, whereas others respond with very little connectivity. There is a certain variability across individuals. And if we focus on that variability, not at the common theme, but at the variability, then we can ask the question, what happens to those people who have a certain pattern of response versus those who have a different pattern of response? And what Kilian found is that he was able to predict 3 years ahead whether those individuals with the, quote, older pattern of response, matched for age, remember, and without cognitive problems at baseline, 3 years before had an older pattern of response, and those showed cognitive decline, for example, in a phonemic fluency task, but across the board, whereas those who did not show that pattern and showed a younger-like pattern actually remained cognitively intact or even cognitively improved. Interestingly, even though these individuals were all, quote, pre-symptomatic Alzheimer's disease, they had all biomarkers of Alzheimer's disease without any deficits in cognition and no complaints. So perturbation, in this case, to characterize the connectivity in such a way that it can predict potential clinical implication. You can use the same approach to get local reactivity measures and relate that to the severity of the cognitive problems with a fairly good predictive value different studies, independent studies, using both ADOS-COG and EMG measures or EEG measures in different cognitive functions. Now, you need to just apply one single perturbation. You can apply trains of stimuli and take the same approach in the living brain that we would take in a slice preparation. So you can apply a pulse, get the response, for example, with EEG or EMG, apply a train of stimuli in the theta burst like you would in a slice preparation, and then check the responses afterwards. And depending on whether you apply intermittent bursting of stimulation as a train or continuous, slower, maintained frequency of stimulation, you can find an LTP-like or an LTD-like plasticity. Now, the terminology is a little tricky. It's not really synaptic mechanism of LTP or LTD, but it behaves that way with a lot of characteristics, pharmacological responses, and so forth. And you can characterize it as a curve with an area under the curve of how long that potentiation or suppression can take to come back to baseline. And if you apply repeatedly, it will take longer and so forth. Now, if you look at LTP-like and LTD-like plasticity in this form, you can do so in different cortical regions, different circuits, and you can do so in different patient populations. And across patient populations, a number of studies by different groups, starting with Giacomo Koch, you may hear more about it later today, can identify alterations of one or the other of these mechanisms in different conditions. To give you two extremes, in autism spectrum disorder, Lindsay Oberman showed that there is an enhancement of LTP-like plasticity and LTD-like plasticity in Alzheimer's disease, even in cognitively unimpaired biomarker-positive Alzheimer's disease. There is a suppression of LTP-like plasticity without alteration of LTD-like plasticity. Now, interestingly, that alteration is related to the risk of cognitive decline in patients with Alzheimer's disease. It's presumably a manifestation of the synaptic toxicity of oligomeric amyloid, and it relates to the decline over time and the presence of cognitive impairment. I think particularly interesting is the fact that, again, we can apply this type of perturbations and measures to characterize individuals over time. And so you can take into consideration the changes in the efficacy of these mechanisms of plasticity in individuals as they age. And you see that there is a steady decline, not great news for any one of us. But you can see that individuals for a given biological age appear to have a different degree of, quote, biological age in terms of mechanisms of plasticity efficacy measured this way than their chronological age would predict. Some have better than expected, others worse than expected. It is sort of a brain health index of sorts, but can we use that to predict what to expect in individuals? So if you look at healthy controls, no cognitive impairment, versus individuals with mild cognitive impairment, and you look at those who have biomarkers for Alzheimer's disease, you find that there is actually a separation, even data-driven separation, that predicts the presence of amyloid-positive PET results based on the responses to these perturbations, and specifically this LTP-like plasticity. So it allows to very early pre-symptomatic detection of the alteration in circuits that might ultimately lead and track with the severity of the cognitive decline. One last point before trying to get it, so why does this matter if you want to help patients with disease? But from a therapeutic perspective, the last point I want to make is that you can, of course, characterize not just the local response, but the distributed response. And what you find is that depending on the individuals and their age and the presence or not of biomarkers of Alzheimer's disease, you get a hyper-excitability locally, an excessive response locally, but you also get a hypersynchrony distributed. It's a less flexible system, if you want to think about it that way, and the responses reverberate throughout the brain in a much more dramatic way, as you can see with EEG raster plotting. So the question then in therapeutics becomes, given those various measures that we can identify at the individual level, can we think of interventions to suppress hyperexcitability, to enhance the efficiency of mechanisms of plasticity, to entrain specific oscillations, or to disrupt the hypersynchrony, or to do all of it and have a therapeutic benefit? And I think you'll hear about different approaches to try to do some of this in the various talks that are to come, and I want to give you one as the last part of my talk, and specifically take you to individuals with a diagnosis of mild cognitive impairment or early dementia who have profound episodic memory deficits. And when you do an episodic memory task in them compared to healthy controls who are biomarker negative, you see a very different spatio-temporal signature, different pattern of response of the brain in the context of the episodic memory task. No surprise there. The question becomes, if we can see that difference, if we can identify the lack of specific components, can we use stimulation to disrupt this pattern, to try to promote the induction of this pattern? And if we do that repeatedly, does that translate in any kind of benefit? In order to do that, we need to identify the distribution of activity that correlates with this pattern and is absent here. We can then use the personalization of that measured brain activity as a sort of roadmap of where to stimulate with what kind of frequency of stimulation and intensity. We can do a multifocal stimulation with alternating current at different frequencies. And when, And when Davide Capone did that, what he found is that, illustrated in two individuals here who over the course of 2.5 years, because of Alzheimer's disease, had progressed to decline in memory, and this is just showing you the memory index score, over the course of a period of 14 weeks of daily sessions of stimulation for half an hour, there is a restoration of their memory function with a real clinical but also day-to-day activity impact. They will become able to recall what they are doing, with whom they are doing it, in a really dramatic, life-changing really way. Which, by the way, opens a huge challenge. How do we sustain that effect? But that's a separate question. It at least shows that interfering with this disruption and restoring the spatio-temporal signature provides a means to have real causal interaction with the behavior and potential therapeutic effect. In a larger study with a sham control group, Alberto Benuzzi and Barbara Baroni have randomized people to sham versus real stimulation at gamma frequency, and showed that, in fact, there was a group difference in the clinical trial in terms of the outcome of cognition, but that it also correlates that very tightly with the degree of increase of gamma, not during the stimulation, but sustained after, as a correlate of that restoration of the spatio-temporal signature. I want to finish with the notion that perhaps the symptomatic improvement that can come because of the interaction with the causal brain pattern that reflects the correlate of the disability might not only go in that feed forward from pattern of activity to behavior direction, but may also have an upstream effect. And with Emiliano Santernecchi and a number of folks, Giulia Sprugnoli has shown that that intervention I just showed you translates not only in an improvement in cognitive function and memory in particular, but a restoration of perfusion deficits in mesotemporal structures. And Meva-Dernot, I think even more excitingly, in a very, very small preliminary study showed that a couple of years ago that there is a reduction in the amount of amyloid and tau deposition in these individuals, upstream, suggesting that the modulation of specific patterns of activity sets into gear mechanisms that can potentially impact the upstream pathology. Presumably, that is because of the fact that the stimulation applied not only has a local impact, but as Alex Sachs' group has shown, Max Kaiser is the first author, there is a specific impact guided and mediated by that connectivity that is altered and reaching deep structures. So now imagine the possibility of characterizing the spatio-temporal signature that is altered for any one function, any one cognitive task, and then providing a montage of stimulation and sending the patient home to be able to do that every day. That is in fact possible as a home-based intervention, and the results that I showed you in the lab are actually being replicated by a number of companies. Neuroelectrics is one of the ones that has such a system for home-based intervention. And of course you can conceive of not only one, but multiple targets for different disabilities, empowering the patient to tell you what is the most disabling of the symptoms. I want to finish handing off to Chris by highlighting that, of course, what I've told you with these transcranial current stimulation techniques, even with EEG methods, is largely limited to the convexity of the brain. But if you want to go deeper in the brain because of the timing of the pathology or because of the involvement of deep node structures, you need different methods. And one such methods that he'll tell us a lot more about is a way to get there non-invasively. But there is different ways to get to the depth of the brain non-invasively. One is actually make the simulation itself reach deeper. There are devices that allow to do that. A much more elegant one that I think we'll hear a lot more from Giacomo later is leverage that connectivity I was mentioning and using the cortical target as a window to reach deeper. But it is also possible to make non-invasive brain stimulation depth selective, and that's the work that Nir Grossman has done. And I won't spend time on this because I want to take this. I don't want to step onto Chris, so just to tell you, he's going to explain this to all of us. But it becomes a way to actually selectively target specific nodes. And it is possible to do it in humans, not only in mice. So I think non-invasive brain stimulation ought to be thought of as an array of tools. It's not a treatment for any one illness. It's not a treatment for dementia. It's not a treatment for Alzheimer's. It's a set of tools that allow to characterize pathophysiology and the correlates of the symptoms that patients have, these correlates of disabilities. That's what I refer to as spatio-temporal signatures of the disabilities. In characterizing them, it allows us to detect early deviations at the individual level. It also allows us to intervene with therapeutic intent. Whether it actually translates into a therapeutic benefit or not is an open question, but the indications show that we can actually help patients while gaining fundamental insights into the pathophysiology. There are many already established applications, including treatment of depression, improvement of cognitive reserve, enhancement of specific cognitive disabilities. I think the particularly exciting potential is to have an even more ambitious goal of using these approaches to not only improve symptoms, but modify upstream the underlying pathology of the disease. I'll stop there and leave you with the notion that we can, in order to do that, remember that focusing on the individual patient rather than doing basic science and looking to translate it into the clinic, if we flip it a little bit around and do a clinic-guided reverse engineering where we start with the patient, characterize her or his deficits, and then look at the underlying substrate, it provides a very personalized precision type approach of lots of N of 1 symptom-based approaches that have a sort of closed loop iterative approach where the clinical translation becomes the driver of the discovery, as it were. Thank you. So I think we have time for questions afterwards, and so therefore what I'll do is I'll introduce you to Chris Butler from Imperial College of London. He's going to talk about temporal interference stimulation of the hippocampus in early Alzheimer's disease. Thank you, Chris.
Thanks very much, Álvaro. Thank you very much indeed also to the organisers of this amazing meeting for the invitation to speak, and especially to be part of this really important symposium. So today I'd like to introduce you, as Álvaro has already indicated, to a novel form of non-invasive brain stimulation that, although at an early stage of development, I think has several advantageous features and holds promise for applications both for research and therapeutics in neurodegenerative disorders. Interesting. There we go. So one of the key challenges in non-invasive brain stimulation is to accurately target some of the structures that lie deep inside the brain where neuropathology begins in certain neurodegenerative disorders such as Alzheimer's disease. And in temporal interference, we use two pairs of electrodes on the scalp to generate two overlapping fields in the brain. These two electrical fields are oscillating at a high frequency, often in the order of several kilohertz, but their frequencies differ by a small amount. So for example, one field might be oscillating at 2000 hertz and the other at 2010 hertz. But where these fields overlap in the brain, there's an amplitude modulated envelope that oscillates at the difference frequency between the two base frequencies. So that would be, in this case, 10 hertz. So the idea is, therefore, that the background frequencies are too high to modulate neuronal function, but the lower frequencies in the area where they overlap, deeper in the brain, can modulate neuronal function. Okay. So my colleague, Neil Grossman, when he was a postdoc in Boston, together with Álvaro Pascual-Leone and Ed Boyden, conducted the first studies in anesthetized mice of this technique. And he showed that with fields overlapping, high frequency fields overlapping at 10 hertz, there was increased, where's my thing? There. There was increased activity of neurons spiking at precisely that 10 hertz frequency with a patch clamp electrode. Moreover, in the hippocampus, where the fields were focused, there was increased activity, as shown here by CFOS, but in the overlying cortex, there was no increased activity. And finally, by varying the ratio of the amplitudes, of the currents of the two electrical fields, you can steer where they overlap, and therefore where the focus at the therapeutic frequency is. And Neer showed that he could steer the current to cause activation in the forelimb or the whisker of the animal, either on the contralateral or the ipsilateral side. Okay. So what I'm going to do today is to talk just about 3 experiments that we've done in London in healthy human subjects to modulate neural activity, first of all, and then memory, and then finally a sort of pilot study in patients with early Alzheimer's disease that is just part of a series of ongoing work that we're doing. Okay, so first of all, modulation of neural activity using TI in healthy human participants. We conducted an fMRI experiment in 20 healthy young adults whilst they performed a hippocampus-dependent memory task with concurrent TI stimulation of the hippocampus. So we used carrier frequencies of 2000 and 2005 hertz with a 5 hertz envelope frequency where the fields overlapped in the left hippocampus. So our aim, therefore, was to stimulate the hippocampus in the theta band range, a frequency that's known to be crucial for coordinating neuronal activity for the encoding of new memories. So there were 3 stimulation conditions. First of all, where the current ratio was 1:1, and that targeted the left mid-hippocampus. Secondly, a sham condition, where the amplitude was 0. And then thirdly, a condition where the amplitude ratio, the current ratio, I beg your pardon, was 1:3, which steered the focus of the hippocampus of the amplitude modulated envelope to the anterior end of the left hippocampus, the hippocampal head, by using this 1:3 ratio. Okay, and the participants received this TI stimulation whilst they were engaged in a face name associative memory task, a task that's known to activate the hippocampus, particularly the anterior hippocampus. So participants saw a face with a name, and they saw 16 of these stimuli, and then after a short break, they were shown a face and asked to choose the correct name for a bunch of distractors. And then they were asked to rate their confidence in their decision. And there were 16 within each block, and then there were 9 blocks in total, 3 blocks per stimulation condition, and those were randomized across trials. And they did all this whilst they were in an MRI scanner, and we were acquiring functional MRI signal for analyzing activity using BOLD. And we defined certain regions of interest in the brain for the BOLD analysis, particularly the left and the right hippocampus, divided into the anterior, mid, and posterior sections, and then the overlying or underlying cortex, anterior, middle, and posterior. Okay, so this is looking at the whole brain, and in the sham condition, what you can see here is the encoding part. We were just stimulating, during the encoding part, not during the retrieval part, because we think that's where the hippocampus was most activated. During the encoding part, you can see activation in the hippocampus here in the sham condition. So learning new face name pairs caused activation of the hippocampus. At recall, we did not see that sort of activation. And you can see here that the activation was predominantly in the anterior rather than the middle or the posterior parts of the hippocampus. When we looked at that T1:1 ratio, focused on the middle of the hippocampus, we didn't see any difference in the encoding activity or the retrieval activity in the hippocampus or other bits of the brain. Whereas when we stimulated the anterior portion of the left hippocampus, we see a reduction in the BOLD signal in the hippocampus during the encoding part of the experiment, whereas again, there was no difference in the retrieval part of the experiment. And focusing in on those ROIs, those regions of interest that I mentioned, here is the left hippocampus, and during the encoding part, we can see that there's good activation of the left hippocampus during the sham condition and during the mid-hippocampal stimulation. But when we're targeting that anterior part with our TI, we see a reduction in the amount of activity in the hippocampus. And there's no change in the recall condition. There's no change in the right hippocampus at any of the conditions, and no change in activity in the overlaying cortex in any of the conditions either. Okay, so we're able to modulate the activity of the hippocampus focally in the anterior portion whilst people are doing a task in a scanner. Can we also modulate their memory? Well, this required a second experiment in 21 healthy subjects, different group. And here, what we did was to use a longer period of stimulation and more behavioral trials. And we didn't worry about stimulating the mid-hippocampus, we just used the anterior. Okay. Again, so they were doing the same memory paradigm, encoding faces and names and retrieving them later. They did it again in blocks of 16 stimuli, but instead of having just 9 blocks, we did 12 blocks of these, and then there was a delay of 30 minutes, and then we did a delayed recall where we showed all 192 faces, and they had to remember as many names as they could of those 192 faces and judge their confidence ratings as well. So the outcome measures here were recall accuracy and response time, both at the immediate and the delayed retest. So what we found was an effect of TI stimulation on participants' performance. Specifically, participants showed a higher proportion of correct target responses for TI versus sham, with no difference in foil or distractor responses. And this difference, which was present immediately after the end of each block, was also present at the 30-minute delayed recall test. In contrast, their response times were not modulated by TI, and neither were their confidence ratings. Now, importantly, 4 times during the experiment, we asked them to judge whether they thought that they had been stimulated or not stimulated on the previous block. And what we found was, and they judged that with a confidence rating, again, from 0 to 10. And we found that across all 4 blocks, there was no difference between sham and stimulation in their judgment of whether or not they'd been stimulated. So they were unable to detect. We've ruled out some sort of confound by the ability of participants to judge whether or not they were being stimulated. So that's a very important thing to be able to do. But what's the possible mechanism by which this theta band TI to the hippocampus may modulate memory? Well, a substantial body of evidence implicates hippocampal theta, as I mentioned already, in the synchronization of spiking activity across hippocampal networks, leading to spike timing-dependent plasticity and improved memory. And we hypothesize that TI improves memory through augmenting endogenous theta synchronization. And this leads us on to the next step, which is seeing whether hippocampus-targeted theta stimulation can have any therapeutic benefits in patients with early Alzheimer's disease. So just to cover some of the ground, recover some of the ground that Álvaro already talked about, what's the rationale for these network-centered therapeutics in Alzheimer's disease? Well, we know that disturbances in neuronal dynamics critically impair neural communication and lead to cognitive dysfunction, memory dysfunction, and other domains as well. And imaging and electrophysiological studies have shown widespread network dysfunction in early Alzheimer's disease, including hippocampal hyperactivity, which we've already heard about a bit, during episodic memory encoding, the slowing of oscillatory activity, and reduced interregional coherence. But dysregulation of intrinsic neuronal firing patterns is not only a biomarker for Alzheimer's disease, but also potentially contributes actively to its progression. So hyperactivity, for example, seems to drive the spreading of tau pathology. But it also places excessive metabolic demands on neurons and disrupts local bioenergetic homeostasis, contributing to synaptic dysfunction and loss. So our hope is that targeting aberrant neuronal activity in Alzheimer's disease may therefore offer a promising therapeutic strategy, both to improve memory, but also, as Álvaro also mentioned, to interrupt this cascade and preserve synaptic and cognitive function. So this is a very early first step, single-blinded, single-arm, that means with no sham condition, pilot study of using theta-band TI of the hippocampus in a much longer period, over 10 days, in patients with early Alzheimer's disease. And we did this in 21 patients who came in, and they had on day one here a baseline PET and MRI scan, I'll talk a bit more about it in a moment. On day two, cognitive assessment, and then 10 days of sequential TI to the hippocampus that lasted 50 minutes. They came into the lab and then went home again. And then at the end, we did a post-stimulation PET and MRI day and a post-stimulation cognitive assessment. And our outcome measures were predominantly here about safety and tolerability. Okay, so this was not primarily an efficacy study. It was mainly determined to look at safety and tolerability to allow further study later on of efficacy. And at the same time, we were interested in whether TI caused any change to hippocampal bioenergy, and we did a PET scan with a novel tracer of mitochondrial density, MC1, mitochondrial complex 1, and we looked at brain perfusion using arterial spin labeling as an MRI technique. And then finally, we were, I suppose, and what I'm going to focus on today is we were interested in whether there was any change in hippocampus-dependent memory, so episodic memory, compared with other types of cognitive tasks that wouldn't be hippocampus-dependent. Okay, so each day the patients came in and they had. Sorry, have I missed a slide somewhere? No, each day the patients came in and they had an initial safety questionnaire where they described any symptoms that they'd had over the last 24 hours that may have been due to their previous stimulation session. Then they had 10 5-minute blocks of TI stimulation plus some memory tasks, which I'll describe in a moment. That lasted about 50 minutes, and then at the end we repeated the safety questionnaire. So this is just one of the patients with his electrodes attached. And these memory tests that they were doing, which were, as I say, predominantly to activate the hippocampus during stimulation to improve the likelihood of TI having an effect, were, I don't need to go into particularly, but these were paired association tasks. So a word plus a scene, or a word plus a scene plus an object, or two words together that the patients had to encode and then later retrieve. And there were a couple of other paired associate type learning tasks as well. But I'm not really talking today about how those results went. Whilst they were doing this, before and after they had done this intervention, they had a PET MR scan during which we retrieved a bunch of different measures, including, as I've already talked about, MC1 density in PET, cerebral blood flow using ASL, and then also some resting state and memory-evoked fMRI and DTI data, which we are still in the process of analyzing. But before and after the stimulation 10 days, they did these baseline and follow-up episodic memory tests. And there were quite a number of these, and I'll tell you briefly about them. A word memory task where they saw 24 words, then they had to later recall them. These were all done digitally. They had to recall them immediately and delayed. There was an object memory task where they saw a number of different objects, sequentially 20 objects on a screen, and then they saw a grid of similar and different objects to each one, and they had to choose the one that they'd seen before, and they did that immediately and after a delay. There was the logical memory task from the Wechsler memory scale, which is 2 short stories that they hear, and then they have to recall immediately and after a delay. And then finally, a recognition memory task for 40 faces, but also 40 scenes. And we know that the hippocampus is much more interested in scenes than it is in faces. They saw them, had to make a judgment about whether they were pleasant or unpleasant, and then later they saw the faces again, and they had to say whether they thought they saw with some foils, and they had to say whether they thought they'd seen them before or not, and give us a confidence rating about that, whether they've definitely or only probably or maybe seen them before or not. And then amongst all of these memory tasks, we had other general cognitive tasks that are much less dependent on hippocampal function, so they're, and therefore unlikely, we hypothesized, to be modulated by TI. And these were tests of executive functions such as digit span, of processing speed, so a motor control task and a choice response time task. Visuospatial processing, we had 4 different tasks here, and lexical semantic processing, a naming task and a verbal reasoning task. Okay. So these were the study participants that we managed to recruit. We had to, as most of these studies that are looking for early onset Alzheimer's disease, we had to go through a lot of people before we got to the ones who were appropriate for the study and who also wanted to do a 2-week intervention daily. So we were referred 331 from different clinicians. We pre-screened 144 of those. We screened 33, and we recruited finally 24 patients. And of those 24, 3 dropped out, predominantly due to imaging-related issues. And you can see in this table the characteristics, the demographics of the 24 patients. The mean age was 73. There were more or less an equal number of males and females, and 4 of them had MCI, and 17 had Alzheimer's disease, or sort of had dementia, early stage dementia diagnosis with a mean MMSE score of 25. And all of these patients, I don't have the slide here, I'm sorry, had serum biomarkers for Alzheimer's disease, sort of ATN, so including p-tau 217, amyloid beta, and neurofilament light, and they were all positive in all 3 domains. Right. So as I say, the sort of main focus here was on safety, and we looked at those questionnaires that I mentioned, and in fact, only 8.5% of all of the 2,310 sessions of stimulation that were conducted led to some form of side effect reported by the participant. And these side effects were side effects that are commonly reported in studies using transcranial electrical stimulation, and were all relatively minor. So trouble concentrating on the task, I'm not surprised in many of these cases that occurred. A bit of sleepiness, some scalp sensations from the electrodes, which is common, and I didn't tell you about the blinding, but we used a small amount of current at the beginning and the end of the sessions with the to try and minimize the scalp sensations. Some neck pain from holding their head in the same position all the time during the task. So relatively minor, 194 counts of side effects in total, and these side effects were very transient in that when they came back the next day, there was a very significant decrease in their prevalence. And with respect to tolerability, we saw no TI-related withdrawal from the study. 98.6% of the sessions were completed properly, and missed sessions were just due to intercurrent illnesses, such as a bit of a cold or a headache, and no subjective complaints about the procedure itself. Looking at the neuroimaging, the TI intervention did not result in any significant changes in hippocampal bioenergy, so either in the density of the MC1 tracer in the amygdala, pre and post, left and right amygdala, pre and post, left and right cerebellum, pre and post, left hippocampus, or in the cerebral blood flow, again, in control regions, amygdala, cerebellum, and hippocampus before and after. So this, in some way, I think, supports the safety of the TI stimulation by demonstrating that repeated delivery didn't compromise local bioenergetic processes. Now, as I say, I wanted to focus most today on cognitive performance, and we had a large number of cognitive measures, as I've already described. And in order, therefore, to make this simpler, we did a dimensionality reduction procedure using multi-level PCA, which allows repeated measures in the same individuals. And we extracted principal components both for episodic memory and for the general cognition tasks. And the episodic memory first principal component explained about 37% of the variance, whilst the general cognition principal component explained about 24%. And here you can see the breakdown of the weightings of each of the individual tasks, logical memory, scenes, etc., in the episodic memory piece, primary principal components, and in the general cognition. And really all the tasks contributed positively and with a very similar weighting in the episodic memory, whereas because there was much more variability in the types of tasks for the general cognitive battery, there was a slight variation in the direction and the extent to which they contributed to the first principal component. But what we really wanted to examine was whether the cognitive measures changed after 10 days of TI. So we took that first principal component for memory and for cognition and subtracted the values in the after and before intervention. And what we found was that there was a significant increase in memory performance in patients following stimulation. And in fact, 18 out of 20 patients showed a positive above zero response to TI in episodic memory, whereas the general cognition tasks didn't show any difference after stimulation. Now, interestingly, the degree of improvement in the first principal component for episodic memory correlated with the baseline mini-mental state score of the patient and also with the volume of the hippocampus on the left across all patients. So what we see, therefore, potentially is that TI may be more beneficial in people with earlier stage disease, although that's, of course, still needs a lot of work to secure that. And now going to look at the individual tasks rather than the principal components themselves, we observed that TI stimulation led to improved accuracy in the immediate and the delayed recall probes of logical memory and object memory performance. And also, we saw that whilst face recognition memory did not improve, scene recognition memory, which we know is hippocampus dependent, also did improve after stimulation. So the only test that didn't show any difference but was very close to significance was word memory performance. Okay, so in conclusion, I'd like to wrap up I hope I've introduced to you something that you possibly hadn't heard of before, explained a little bit about the mechanisms by which TI works, and that it can modulate neural activity and memory function in healthy individuals by targeting deep structures, something that's highly desirable in non-invasive brain stimulation techniques. And that the finding from our proof of concept study in AD provides compelling evidence that multi-session TI stimulation of the hippocampus is safe and may enhance episodic memory in early stage Alzheimer's disease. Of course, the main limitation of this study, as I mentioned right at the beginning, is that it was a pilot study with no sham control. So we are currently now doing a new, bigger study, which is double-blind, sham-controlled crossover of TI stimulation for a slightly shorter period, for just 1 week, targeting again the left anterior hippocampus in early Alzheimer's disease. And maybe soon I can come back to discuss the results of that study. But I'd like to close by saying thank you very much to everyone in the team who's contributed to this work, especially Ketty Alanya, who did most of the design and stimulation of the patients, together with Julia Barella, lots of our key collaborators and the funders of this work. Thank you very much.
Thank you very much, Chris. So now, Guglielmo Foffani, who is recently joined the CIEN CIBERNED in Reina, Sofía from CINAC, where he's continuing to be connected with, as well as the Hospital de Parapléjicos in Toledo, I think.
I'll explain it. So
I'm
in the middle of a change, so it's an interesting moment.
But he's going to tell us about transcranial static magnetic field stimulation in movement disorders. Thank you very much.
Thank you so much. So yes, so this is the first presentation that I gave with my new institution, which is CIEN, Fundación CIEN. So things have changed since Pascual invited me. I'm very thankful for this invitation. And now I'm on this side. But all the work I'll be presenting have been done at tSMS CINAC and has started at Hospital Nacional de Parapléjicos more than 10 years ago, which as now I've not have an official affiliation anymore, but is still cited in parentheses to recognize the origin of the story. So, acknowledge first my conflict of interest. This is irrelevant for the talk with Neuronica because the company works on adaptive deep brain stimulation in Parkinson's disease. I'm not going to talk about that, but I am co-founder of Neurec, which is we have been developing through the startup the technology for static magnetic field stimulation. And this is the group at tSMS CINAC, not yet at the Fundación CIEN, and in yellow we have the key people that have been involved through the years in the human studies that I'm gonna present, particularly now Claudia Amman, who is at CINAC with me. And these are the main collaborators. I want to mention especially Antonio Oliviero at Hospital Nacional de Parapléjicos. Founders, so I get everything out of the first slides, and I can start on the concept. I'd like to start on something that it's kind of obvious in this forum, which are the cost of brain disorders, but give a sense and some numbers to how big they are. This is already more than 10 years ago, so probably numbers went up. And the point is that we have a problem of sustainability, in a sense, that on society. Of course, a lot of these costs come from the high cost of developing drugs, effective drugs, which is particularly challenging for brain disorder because it's not so easy to get to the brain. So this is an additional challenge that other diseases do not have. And of course, challenge for some become opportunities for others, and this is an opportunity for brain stimulation, which directly act on the brain. And Álvaro presented all the families of brain stimulation techniques, and there are, I'm not mention them all, but just to put them on a slides related to currents, and I put tSMS in the current category because there are induced current in the brain, but we could discuss about that. We have ultrasounds with the family from lesion to neuromodulation. And finally, our magnets, our static magnetic field stimulation, which is the one I will talk about. And if we put a couple of axes, like safety and depth, of course there is an obvious categorization between invasive and non-invasive. So invasive are more on the low safety, I mean, relatively, of course, and high depth, capability to go inside the brain, and all the way in the transition down to the one that is possibly most safe and definitely not allowing to go in depth, which is static magnetic field stimulation, which is the only one which is technically a class 1 device is the only one that is a class 1 device because there is no energy involved in the stimulation. It's just a static magnet. And if we keep the safety axis and put portability on the other axis, we have that invasive techniques like DBS or a lesion are by definition fully portable. And the other can be on different level of portability. tSMS, for example, is not possible to make a home-based tSMS at the moment. We have seen some example with transcranial direct current or alternative current stimulation, which can be delivered home-based. And transcranial static magnetic field stimulation is sort of a champion of the whole base because of its simplicity. So the story started more than 15 years ago at this point, or around 15 years ago, with this paper in which, and the original idea was Antonio Oliveira's idea that said, oh, let's try to put the magnet on the motor cortex and see what happens. I look at him and say, okay, do it and let's see, and then we talk. And then I realized it was a great idea because of this simplicity. It was soon recognized as possibly making things as simple as possible. And the technique is just a magnet. It's the same type of magnet, is a neodymium magnet, the same that you have on your fridge, just bigger and more, of course, more with much higher intensity, but it's non-invasive, it's inexpensive, it's easy to apply, it's the ideal for sham studies, and it's fully portable. It also has a very neat physical characteristic, which differently from electric field, the magnetic field is not affected by the tissues. So you know exactly what magnetic field will be at the target, just based on the geometry of the magnet and on the distance. These are the type of helmets that we now develop and use for the stimulation, depending on the target. And this is an example of a subject, myself, in the lab preparing an experiment. So to see the path since we started, 2010 we created the startup, 2011 the first paper demonstrated that we could modulate cortical excitability at the motor cortex. Safety study, first in human in patient, just a physiological study. We transitioned to long-term effect in terms of plasticity, like distant effect, and I will talk about some of these results. And finally, we enter into some clinical data, so the first randomized controlled trials, which we published in 2022. And we were able to actually modulate also distant deep activity. And then we are here, 2025. So I will first focus on motor cortex. Of course, being in an institution devoted to Parkinson's disease, all this story I'm telling is the part on motor areas. There are some additional literature and studies by us and in other regions, which I will not touch. So the two key papers were modulation of cortical excitability and the transition from short-term depression-like to long-term depression-like. So the typical experiment on motor cortex on these type of techniques is give a number of pulses to measure excitability of the motor cortex before and after the neuromodulation technique, and what you measure is the amplitude of the motor evoked potential elicited by the pulses. So the measure is a direct measure of corticospinal excitability. With 10-minute duration of static magnetic stimulation, the effect lasted few minutes, less than 10, let's say, which is biologically interesting, but clinically not so exciting. So what we saw is that increasing the duration of the application, the duration of the effect could be increased by at least half an hour after the application. So now we are already in this transition from short-term depression to long-term depression-like effect. A long-term depression-like effect are the ones that are supposedly necessary to accumulate over the days and possibly induce clinical effects. So with this result, we can categorize the technique among inhibitory techniques. And this is a definition that is based on motor cortex, corticospinal excitability, and it's pretty standard, and we can discuss whether is a good definition or not, but I think helps put the technique among the others that are better known. So from there, something crucial happened to me in around 2020, 2021, which is a conversion to Bayesian statistics. This is like sample falling from the horse on the way to Damascus. And what happened to you is you become much more skeptical of what is published around, because you see all the problems that you have not seen on yourself before, and more rigorous on your research. At the practical level, the asterisks that you will see from that date in my talk and in my paper are not p-values anymore, because p-values are worthless, but that's another story, but are bias factors, and we can have a long talk about it. So I'm becoming a champion of, after a conversion, you have to tell people that that's the right way to go. So here we have our first clinical trial. This was with patients with Parkinson's disease and levodopa-induced dyskinesias. The logic was very simple. Since dyskinesia is an hyperkinetic movement associated with hyperexcitability of motor cortex, if we reduce the motor cortex excitability, we should improve the dyskinesia, and this was home-based. Home-based in the sense that we give the patient the possibility to choose whether to come to the hospital and have the treatment in the hospital or have it at home. Out of 50 patients, or more or less, just one preferred to come to the hospital because she was very close by and she liked us and she wanted to come and say hi and have an interaction every day. But was clearly preferred the home-based version. This was it was the very first trial done with this technique in any population of patients. So we kept it short, a couple of weeks. So we were 9 sessions over 2 weeks, and we measured basic clinical. So PDRS and the dyskinesia scale before and after, and some subjective measure before and after. 25 and 25 patients, a little bit less at the end, but that was the order of the numbers. We did not meet our primary outcome, this is important, which was the objective measure of the dyskinesia with the clinical scale, but we did meet an important secondary outcome with moderate Bayesian evidence about subjective improvement. The patient that received the real treatment reported a greater improvement compared, in this scale, this is the patient global rate of change, so 5 is neutral, and more than 5 is improvement, less than 5 is getting worse. So it's not a positive trial in a regulatory sense, but a promising result for such a short period of treatment. Again, 9 sessions. I'm going in the wrong direction. So we also have some pilot data with 1 session, just 1 session in essential tremor. This is very simple. The logic is the same, 30 minutes on the motor cortex and measuring postural tremor and kinetic tremor in patients with Parkinson's disease. And we do see surprisingly moderate evidence of bilateral improvement after 1 session. So this will have to be verified with a sham-controlled study if it's a true bilateral improvement or there is some sham effect, but still it's interesting. The other interesting thing of this work, this is a very, very simple work, and is more than 1 year in peer reviewing, which is it's kind of what's going on nowadays about the peer reviewing system that is getting crazy. So just to mention my frustration in public. So the other transition, the other line that we did was move from motor cortex to supplementary motor area. What's the rationale of that choice? Is because we have this cortical pathogenic theory according to which top-down hyperactivity or hyperexcitability could play a role to the the retrograde neurodegeneration of nigrostriatal terminals in the striatum. And so the supplementary motor area in a very small area have the somatotopic representation of the entire body, whether normally when we go in motor cortex, we put it on the hand area because it's easy to study, but clinically it makes more sense to try to neuromodulate the entire body representation. So we went there. Of course, the disadvantage of going to supplementary motor area is that we cannot have the motor output anymore. So we used resting state fMRI before and after the application of the 30-minute static magnetic field stimulation. And we could measure first local effect just below the magnet. There is clearly some local effect. And then the nice thing of neuroimaging that you can study the entire brain. So we have this nice distant cortical effect related to the network of the sensory motor area. Then, of course, there is this little issue. And the fallacy of affirming the consequent is one of my favorite fallacies. And it's a trap in which we enter very easily and all the time. And in the version related to functional connectivity, it works pretty much like this. So if there is a change in neural coupling, there is a change in resting state functional connectivity. But the other way around, we cannot so easily go. If we observe a change in functional connectivity, we cannot infer that there is a change in coupling. 95% of the paper that we will publish do that inference, but there is a known problem. In this case, it's very easy to see where the fallacy comes from, because if you do have a change in local activity, then the mathematical measure of functional connectivity is dependent on that local activity. So in order to infer a change in functional connectivity, you have to make sure that it is not dependent on the change in local activity. Of course, since we are putting a neuromodulation device and we are modulating local activity, we will have that problem. So it took us a lot of effort to try to develop a methodology to take care. We call it ISAC, which is intra-region structure, amplitude, and asymmetric covariation of local activity. Just stay with the ISAC acronym, which is easier. And with that, we could demonstrate that our stimulation could actually change corticostriatal activity. And that was an important direction in our Parkinsonian view and try to modulate the top-down activity. Of course, this is not a direct deep neuromodulation. It's a local neuromodulation that affects a distant structure in the striatum, was specifically to the motor striatum, so not in the other representation of the striatum. So we are pretty confident that we are modulating corticostriatal activity. And this is pretty much the synthesis, right? So we are modulating locally. Of course, there are distance effects to the network at cortical level, but also at subcortical level. So with this, can we do the jump that everybody is trying to do from symptomatic treatment to disease-modifying treatment? Well, the first step that we are doing is a pilot study. This is open, giving patients the helmet to do SMA stimulation for 2 months at home, measuring all kinds of things before and after. And the thing that I can anticipate, and I can do it because I'm using Bayesian statistics, because otherwise I would not be allowed to do this, is to show some preliminary result, not with the full N on sleep. So we are seeing a moderate to strong evidence that we are improving sleep as measured by the SCOPA scale. So this is subjective sleep, and we'll have to verify in a different study whether there is an improvement in objective sleep, because since the supplementary motor area is involved in agency, all these type of things, that there is a big difference between objective sleep and what the patient report or the subject report. We are not very good at reporting our sleep in general. But still, it's a very interesting and promising result, because sleep is, of course, very much associated with neurodegeneration in bidirectional ways. So improving sleep can have important consequences. And I would like to end mentioning a study that is not done by us, but is done with our helmet by a group in Rome on amyotrophic lateral sclerosis. They did the first, and the logic there is that there is much more evidence, mechanistic evidence about the effect, the top-down effect of hyperexcitability on the neurodegeneration process through glutamatergic effect, toxicity, that's the word, glutamatergic toxicity due to hyperexcitability. So what they did was first a pilot on 2 patients. You can see on the y-axis is the clinical scale of the patient, x-axis is time in months. The typical neurodegeneration and impairment is very fast in patients with ALS. At point 0, they started daily, twice daily session on to reduce motor cortex excitability with tSMS, and these 2 patients dramatically slowed or stopped their neurodegeneration. So this was pretty impressive. They did a follow-up phase 2 placebo-controlled randomized clinical trial, which results are pretty interesting. Again, I have to say, they did not meet the primary outcome. So what you see here is a long-term follow-up after the initial randomization, so in which they measure the tracheostomy-free survival probability up to 24 months after the beginning of the therapy. And you can see that the 2 groups, real, that started with real or started with sham, separated quite clearly in the long term. Again, this result should be confirmed in future trial, but in a disease like ALS, it is very promising. And I want to put the attention of this small but important detail. 3 sessions per day, 2 hemisphere, 30 days per month, 6 months, this is 1,080 sessions per patient. And this is feasible because you can simply leave the helmet to the patient and do it at home, and the effort in terms of sustainability is low on the side of the health system if this was to be implemented. So it allows to perform much longer protocols that we could not even think with the tMS classical neuromodulation. You could with direct current stimulation or current stimulation in general. So I think it's a very important direction, the home-based long-term treatment, especially in the context of neurodegenerative diseases. And the discussion is, okay, are we ready for clinical use? Are we not? Of course, in a rare disease like ALS, it's different than with a prevalent disease like Alzheimer. So we could discuss how much data is necessary with a class 1 device to actually treat patients, but is a process. To summarize conceptually, I think we have, and in the literature now, there is a strong evidence that tSMS decreases cortical excitability, and we have this classical path, of course, the pathophysiological path. If cortical excitability is associated to signs or symptoms, you could, in principle, improve signs and symptoms by reducing the cortical excitability. If the cortical excitability is directly related in the pathological process of the disease, as is the case in ALS, and maybe there is a possibility also in Alzheimer, there is a line of thought that goes in that direction, then it could also induce a slow down disease progression in a pathological sense. And of course, there is this middle way. If it improves sleep, which we should confirm, then there is a third path toward the improvement of disease progression, which is through improving sleep, which I think this would be a general path, a more disease-specific in a sense, which I find it attractive. And this is the end of my talk. Thank you very much.
Thank you. Thank you very much, Guglielmo. So, last but not least, Giacomo Koch from the Fundazione Santa Lucia in Rome is going to tell us about personalized neuromodulation of the default mode network for the treatment of Alzheimer's disease, foundational insights and next steps. Thank you, Giacomo.
Thank you very much, Álvaro, for the introduction and for chairing this session, and thanks, Pascual Sanchez, for inviting us. I'm sorry, I'm the last, so I will try to be as concise as possible. And interestingly, on Saturday, I will give the very same talk in Rome, International Society for Dementia, and it's scheduled at the very same time. So I think that's something that I should be aware of. So very briefly, my disclosure, what is relevant for this talk. I'm a scientific co-founder of a company named Synaptica Therapeutics, who is involved in precision neuromodulation. And I will directly start with a general overview, and after the very nice talk that we heard today in this session, this is an easier task for me. So the concept here is that we can use non-invasive brain stimulation to counteract synaptic dysfunction at the end. This is the assumption that I will make, and I will try to convince you that this is a valuable therapeutic option. So you are experts in the field, so you know better than me that it's a very long journey from the progressive accumulation of pathology that occurs through several years, and then either interaction between neural inflammation, amyloid, and tau leads to synaptic dysfunction. And at some point, the brain is able to compensate to this pathological insult. But when synapses start to degenerate, then there is a progressive breakdown of connectivity in the long-range pathways between the more relevant areas of the brain, and that's exactly when cognitive symptoms arise. So if we take in account of this model in which we believe there is a circuit-based dysfunction originally that progressively involves broader and broader circuits, and this induces several physiological consequences, we may actually try to use neurophysiological methods to pick up and understand better what's happening in terms of synaptic dysfunction at the single patient's level. And this is the challenge that we are facing now. So first of all, we can identify some features that have been mentioned before already by Álvaro Pascual-Leone, like hyperexcitability is one of the characteristics that can be picked up by neurophysiology. Of course, we know from animal models how relevant is the disruption of gamma activity, which is involved in cognitive function, including memory, and is fundamental for several cognitive rules. Cortical plasticity is another very important feature of healthy brain activity that is damaged in course of Alzheimer's disease, and we can measure this in our patients. And finally, to a broader extent, we can move from local circuit dynamics towards more extensive impairment of brain connectivity. And I will focus my talk here on the default mode network, because the default mode network is the most impaired circuit in Alzheimer's disease, and it is also responsible for some memory function and shows from the very early phase of the disease, as you probably know, preferential accumulation of beta tau. And its dysfunction can actually be seen by different angles depending on the different methods that we use, such as PET, fMRI, amyloid PET, and so on. So in the field of neuromodulation, and I think this is a slide from one of your paper, Álvaro, we can use actually tMS with a twofold approach. On one end, as I mentioned, we can try to use our neurophysiological tools, non-invasive brain modulation, in order to detect biomarker of synaptic dysfunction with the perturbation-based approach that Álvaro was describing nicely before. And on the other end, we can learn more from these biomarkers and build protocols of therapeutic application that can be more meaningful potentially and personalized. So in this idea, we believe that especially TMS in combination with electroencephalography may be very useful. It is a method that has some technological issues that has been solved more and more in the past years. And nowadays, finally, we are actually capable of record the activity of the brain in different areas that can stimulate it by a TMS pulse. And this TMS pulse can be a probe of how efficient is that brain area in terms of neural activity and synaptic activity, not only locally, but also in terms of connectivity. And the beauty, I think, of TMS-EEG is that by using a simple recording, actually you can get a very impressive amount of data that then you can analyze and extract different features, such as, for instance, evoked potential, classical evoked potentials, but also dynamics of connectivity and change in oscillatory activity. So I will very briefly show you some clinical example now, because we are trying to translate this model into the clinical ground. And for instance, we were able to see using tMS-EEG that it's possible to identify hyperexcitability in the brain of patients with Alzheimer's disease in different areas, especially the precuneus, which is part of the default network, the lateral prefrontal cortex and the lateral prefrontal cortex. And as you can see here, tMS-EEG can be helpful to detect striking differences in terms of response to the TMS pulse that can indicate hyperexcitability. On the other end, we can do the same exercise by measuring evoked oscillatory activity, and we can precisely measure the amount of reduced gamma or high-frequency oscillatory activity in several areas of the brain, including, again, the dorsolateral prefrontal cortex and the precuneus. And then what I think is very relevant for the challenge of clinical translation is that these observations need to have large cohort of patients. First of all, because we are definitely going into a stage in which we consider Alzheimer's disease as a complex disorder. We heard this morning how relevant is the impact, for instance, of APOE genotype. And there are several factors that may actually contribute to different alteration at single patient level. So the larger is our cohort, the better we can understand the interrelationship among, for instance, clinical profile, CSF profile, and the neurophysiological features of different patients, and combining this, for instance, with the alteration of specific neurophysiological markers. In this case, we correlate these different aspects with gamma activity. Again, I have to thank Álvaro for already mentioning this, and of course his group was pioneering the idea that we can use TMS to map actually cortical plasticity across lifespan and in context of the disease, and we were more interested in defining the boundaries of this alteration in the context of Alzheimer's disease, and we described this prominent alteration of impaired LTP, like in patients with Alzheimer's disease, and again we tried then to put down in the context of the clinical ground, and we started to understand how actually these measurements can be considered potentially important physiological biomarkers of disease progressions. For instance, if you measure cortical plasticity at baseline in these patients, you can then predict how fast they will progress in the following months. And in our cohort, the ability of prediction of plasticity, cortical plasticity measured with TMS was actually higher than, for instance, CSF biomarkers. And again, it is very important to underline how this biomarker can be sensible to the underlying pathology. This is just one example which is relevant, again, related to the very nice symposium that we heard this morning. So, for instance, APOE genotype has a strong impact on the expression of plasticity in these patients, and also modulates the interaction between APOE plasticity and CSF tau levels, which is, I think, a very fascinating aspect, but we don't have time to get more into detail. Anyway, again, another example on how these biomarkers can be relevant and tell us how this condition may progress. This has been applied for patients with MCI, and we were happy to see that, again, measuring LTP-like plasticity was predicting conversion to a D in a very specific and strong manner. Now, let's again move forward to identify impairment of brain connectivity in patients with Alzheimer's disease, and in this case, we use tMSG. As I mentioned before, we believe this is a very powerful method in order to identify at a single patient's level the profile of alteration in connectivity. In this case, you can see what happens if you deliver a single TMS pulse in the deformer network. Our target area is the precuneus, and if you apply a TMS pulse here in AD patients and healthy volunteers, you see how different is the propagation of the EEG signal in the network between the two conditions. And what is very important is that we can actually quantify this impairment of connectivity with a very specific also temporal domain analysis. And then we tried again to systematically investigate this alteration and combine eventually with fMRI. We found a strong correlation with neural activity as detected by resting state fMRI. And more interesting, I think it is also possible to understand which are the white matter bundles that transfer the information from the precuneus to other networks, areas of the network. And then the next step is, of course, if we want to have a closer look into the different features at a single patient's level, it is very important to investigate more in detail what happens within a certain area. So the beauty of TMS is that it has a very high spatial resolution, and we as neurophysiologists know this since the very early studies in the motor cortex. For instance, if you use a TMS pulse and you move your TMS pulse by just 1 centimeter over the motor strip, you may be able to selectively activate one or another muscle, let's say, of the end. So it's very specific. So if we transfer this model into now this connectivity approach in the precuneus in patients with Alzheimer's disease, we can notice that it is very different whether you stimulate a spot which is located, let's say, in the middle of the sulcus, you move 1 centimeter on the right, on the top. So we build a grid of 9 spots, and this is just an example of one patient. So you can see the TMS EP evoked potential, and Romina and Esposito and Elias Cazula are mostly working on this. And you can see how different is the response in terms of local excitability. And then we can build a map of connectivity and identify the spot within the precuneus that has the stronger connectivity with other areas of the deformer network. And these are the 2 examples that show you, first of all, how relevant it is to have this approach, especially in terms of single patient's differences, because if you stimulate the same spot in one patient or the other, you may get very different responses. So it's very important to have relevant knowledge on what's happening. And for us, this is the basis for driving an informed and personalized therapy in the context of Alzheimer's disease. So overall now, we can transfer to the second part of the talk very briefly, which is the idea that non-invasive brain stimulation methods may counteract synaptic dysfunction, and we recently reviewed this idea in this paper, but again, Álvaro already and Christopher were mentioning this in their talk before. So what's the general framework here? We now know that non-invasive brain stimulation may enhance cognition and can do that locally, especially TMS, by activating mechanism of plasticity and increasing oscillatory activity, and then indirectly, as also Guglielmo was showing, inducing remote effect in interconnected nodes. Animal models now are helping us to better understand and confirm whether this is the case in the context of Alzheimer's disease. So we recently reviewed the literature, and we were quite impressed by seeing how many evidence are now popping up from animal models showing, and Annibale Antonioni was actually doing this very hard work, and how, I mean, consistent literature in animal model is showing that RTMS is actually capable to exert profound effect in terms of increasing growth factor, changing and decreasing neural inflammation, increasing glutamatergic transmission, increasing the expression of pre- and post-synaptic structural proteins, and then this can be transferred and also seen in terms of a strong effect on amyloid production and deposition, increased clearance of toxic products, and also finally enhancing the synthesis and bioavailability of neurotransmitters. So we have now very solid basis in terms of animal models, this is important for us because then from a neurophysiological perspective, we can see and read the counterpart, which is more systemic neuroscience. And from a system neuroscience perspective, we can use the methods that I showed you before in a combination of neurophysiology and neuroimaging to map changes in cortical plasticity, structural and functional connectivity between brain network, structural integrity of the gray matter, and we can put all these things together in order to build computational models that may help us to identify digital twins for the brain of these patients. So now, if we go straight into the clinical data, what is the current evidence? There have been several attempts in order to stimulate different areas of the brain by using especially TMS and TACs, and TDCS, sorry, so far. And the most preferential target is the dorsolateral prefrontal cortex and also the temporal parietal cortex. As I mentioned, we focused mostly in the precuneus because we think this is the gate for access to the deformal network. And if we revise the, in terms with the meta-analysis, the global effects on cognition of TMS, you can see by the slide how favorable are overall the studies that have been analyzed in this meta-analysis by Simco and colleagues. So this is the overall effect of TMS. TDCS goes in the same direction, probably effect size is a little bit milder, but still consistent with this idea. So let's now move forward in this final part of the talk to the clinical implication and what happens if we use our personalized methods of stimulating the precuneus with TMS personalized by EEG and neuroimaging in order to induce change in the network and hopefully counteract the cognitive decline. So I'm starting with this paper that we published some years ago that was a sort of proof of principles in which we show with a crossover design that 2 weeks of treatment with the RTMS of the precuneus, the deformal network, were actually able to improve memory, long-term memory. In this case, we used the Ray auditory verbal learning task to some extent. And in parallel, we were also seeing increase in neural activity of the precuneus and an increase in high-frequency oscillatory activity in the same network. So this evidence provided as the basis for running a proper clinical trial in which we introduced some aspects of novelty. So for the first time, our tMS was applied for in a longer treatment duration for 24 weeks. And we designed the trial as in the case of a pharmacological intervention. So we decided to have a sufficient time window that could allow us to see effects in terms of reducing the progression of cognitive symptoms. The other element of novelty was the TMSEG personalization targeting the DMN, that I showed you before. And the primary outcome measure was CDR sum of boxes, and then a secondary outcome measure standard for pharma trials. This is the overall designs of over 50 patients were randomized into two groups that received TMS or sham, which is placebo, during 24 weeks. And this paper was showing that actually there was a favorable effect when patients were stimulated with active RTMS as compared to sham for the primary and secondary outcome, and especially a strong signal in terms of also not only relatively slowing down the progression of cognitive dysfunction, but also stabilizing the functional independence of daily living, which we know is a very important factor. And then we tried also to combine this evidence with our new physiological tools, and we were happy to see that neural activity was stabilized within the network before and after treatment. In the group treated with the RTMS, there was an increase in oscillatory activity, while a patient with sham tended to show a progressive decline of activity in the network. In a subset of patients, we were also interested in analyzing potential changes in MRI structural and functional connectivity, and we were happy to see that functional connectivity increased as expected. But what was most interesting to us was to see that actually atrophy was almost stopped in the network that we stimulated from macrostructural analysis, standard Boxer-based conformity. And then we sent our data to an independent group of researchers in Oxford, and they applied another method which aimed to evaluate the microcolumnar integrity, and they show also preserved microstructure in patients that were treated with RTMS. So this was an important validation from an independent group. Recently, we extended this approach to a longer period of stimulation. In this case, the design was the same, so we applied personalized RTMS during 2 weeks intensively in 10 days, and then we maintained treatment up to 52 weeks in one year. The overall results, again, were significant. So there was a difference between progression of CDR sum of boxes, which was our primary endpoint. And again, stronger signal was probably in secondary endpoints, such as independence of daily living, ADAS-Cog, Mini-Mental, and also, interestingly, something happened in terms of reducing the burden of neuropsychiatric symptoms. And also, this was associated with changes in connectivity in the forward network, and we did also recently some time-saving analysis that is actually explaining better the potential clinical impact and the duration by which long-term treatment with RTMS may actually save a healthy period of life in these patients. And very finally, I would like just to mention the next step. So we are thinking that, of course, we have been discussing in this panel the very interesting area that we are living now. There are several techniques that can be used to modulate the brain, and we think that also the combination between these techniques may lead to further enhancement. So in this case, we are developing a new model in which we are combining high-frequency RTMS, intermittent theta burst, that is supposed to enhance plasticity with TAX, which is supposed to enhance oscillatory activity, especially in the gamma band. And we are doing this because previous researchers were able to show that a combination of these two techniques may actually be valuable in enhancing plasticity in the motor cortex. We have been replicating this in the dorsolateral prefrontal cortex, and now finally we use this approach in the precuneus in LT subject to see whether it could be behaviorally relevant, apart from being physiologically relevant, as capable to induce plasticity. So the task that we use in the study was a face name association task that has been explained before by Christopher. And we use tMSEG and fMRI to see the effects. And so a single session of combined ETBS with TAX was able to increase the performance, the accuracy in this memory task in these early students by a significant extent. And what is important for us is that this significant effect was reached only with a combination of TMS and TAX, but ITBS alone was not different from sham condition. And then when we look in a subsequent experiment, we replicate the study, and then we expanded the follow-up for up to 1 week, we saw a consistent consolidation of the improved memory. So there was a strong signal that increasing neural activity in the precuneus and plasticity by means of ETBS combined with TAX was actually able to enhance memory engrams related to face name association task. And then we use our tMSEG methods to map changes in brain activity. Again, we found increases in gamma activity as predicted, and we also use fMRI to show increase in connectivity between the precuneus and the hippocampus bilaterally through specific white matter bundles that are described here in this panel. There was a strong correlation between behavioral neurophysiological changes and structural integrity of this area. So what we are doing now, we are transferring this again to the clinical ground, and we recently received a grant from the Italian Ministry of Health to do a clinical trial in which we are estimating the effect of combined magnetic and electrical stimulation of the deformal network in the mild AD patients, and the trial is ongoing. So I think we can go straight into the conclusion. I hope I was able to convince you that TMS, especially in combination with EEG, can be a novel biomarker of synaptic dysfunction in AD. We believe that cortical plasticity, upper excitability, gamma oscillatory activity, and DMN connectivity are probably the most relevant measurements. We can agree that RTMS has the potential to slow down cognitive and functional decline in Alzheimer's disease, and personalization is key. Of course, what we need to do now is to definitely further validate and automatize these methods, because these methods require a substantial load of measurements from expert neurophysiologists, and it needs to be distributed to all the centers, and definitely the challenge is to move forward in proper multi-center, multinational phase 2 randomized controlled trials that are needed to validate the potential of this approach. And finally, last but not least, of course, we need to understand better the mechanism of action. I mentioned before animal models providing us interesting clues in terms of interrelationship with beta-amyloid tau neuroinflammation synaptic activity, but this needs to be disentangled more. And finally, again, an important concept is that we believe that in the future, the combination of OTMS with gamma tax or temporal interference, static magnetic field. The idea is that really we have a very strong armamentarium, and we need to understand better how to combine these tools in order to have a more valuable and effective therapy for our patients. So I thank you very much for your attention. This was my last slide.
So we went a little bit over time, so we have about 10 minutes of questions. Just to remind everybody, the session this afternoon will be starting 15 minutes later, so that there is enough time to eat. But we have some time. Hope some of you have questions. Yes? There's a microphone coming, yeah.
Thank you. I guess that you are anticipating, based on what you just mentioned, that you will have to, most likely to combine these approaches with regular pharmacotherapy. Okay? So do you have any evidence yet?
Yeah, so I think the question, just I don't know if everybody heard it properly, is about combining pharmacological interventions with the neuromodulation interventions. And I think there is. It's a great question, thank you, and I presume many will have comments, but there is indeed increasing interest in the possibility of leveraging medications that will enhance plasticity by themselves and use that as a way to increase the effect, that will promote consolidation of the effects and therefore sustain the benefit, that will suppress excitability and therefore enhance. So I think what is and the data there, I don't think in Alzheimer's per se so far, but certainly in depression, that's where we are with these neuromodulation techniques, combining it with the cycloserine, for example, with enhancement of the effect, or with ketamine with enhancement of the effect because of the modulation of plasticity. I think personally, and maybe if I may challenge them, expanding on your question, I think the point of what is the mechanism of action of these techniques, are they different or are they common elements? So it makes sense to combine if they're different things that you're leveraging. It may be just more perturbation in a non-specific, non-physiologic way if they're the same. And I personally don't think we know. I think we have the benefit of translatable phenotypes that one can measure in animal models, but I think it's a critical question to figure out what to best combine with pharmacology. Any thoughts on both aspects?
No, I think yes, it's a great point, and of course, but the problem is that when we try to combine this with drugs, it makes perfect sense. But still, we need to be careful step by step, because before we need to clarify better the mechanism of action. In the context of Alzheimer's disease, I think everybody now agrees that Alzheimer's disease will be treated with a combination approach, as in the case of oncology. And in this big scenario, I think that non-invasive brain stimulation may play a role, because especially in terms of safety, and this is something that is very important when you mention combining different drugs, right? Safety can be an issue, but in case of non-invasive brain stimulation, it is extremely safe. This is something that it's very relevant and can be highly synergistic with several aspects, as also the animal models are suggesting. And especially, I will start with the idea that there are also several drugs under development that aim to expand actually synaptic activity, a specific target on the circuits related to synaptic transmission. So probably that's an easy way to combine.
Thank you.
More questions?
Hi, thank you very much for your great talks. Every time I think about synaptic loss as the best correlate for cognitive decline in Alzheimer's, and now hearing your talks, I keep thinking, how do you view these brain stimulation techniques? More like primarily disease modifying, like altering pathology, amyloid, tau, inflammation, and ultimately restoring the brain function, or more like enhancing brain resilience and network connectivity?
Start.
Sample. Chris, get it started.
Well, I mean, I think we don't know, and that's been, I think, one of the key messages that have come out of this morning's presentations. I suppose one of the key differences between something that might help cognition directly and something that might modify the course of disease is the duration and sort of feasibility of extended periods of treatment, which is really what we heard about from Guglielmo, about sort of home-based therapies. And I think this is where we'll start to be able to explore those questions in much more detail. We're going to have treatments that are minimally invasive, treatments that can be used over long periods of time in patients' homes in order to be able to detect potential upstream effects on sort of pathological biomarkers. But I'll leave it there in terms of evidence.
If I can add a thought, of course we have an historical background or bias, if you want, with non-invasive brain stimulation on the physiological part. So on excitability and on things that are measured with neurophysiology, we tend to link with symptoms. But I think it's, if you start going away from the neuron and think on the effect of glia, on the effect of all other kind of things, and then the link with the mechanism of the disease could be closer than we can think. Of course, there is a connection between hyperexcitability and disease mechanism, so we have that link there, but there is evidence that you could interfere with protein and astroglial function through non-invasive brain stimulation, which might not be as easy to measure in humans, but it gives another path toward disease modification that is very direct. So at the end is a combination of the different viewing and of the different effect of the different systems that we can think.
Yeah, I think it's going to depend. I've become increasingly convinced that, as your question implies, early detection of dysfunction, like Giacomo was also showing, can predict and therefore can potentially be a target to prevent the progression of the disease from MCI to dementia, from dementia in terms of severity. And I think that's super powerful in terms of connecting with promotion of resilience even. And so I think that's a whole line. But at the other end, I think thinking of it from the substrate of specific disabilities, patients with impulsivity, patients with Capgras, patients with very concrete disabling symptoms of their dementia, you can identify the substrate and actually target it and improve it, having not so much a disease-modifying effect, perhaps, but a very, very valuable symptomatic effect. And so I think that there is going to be increasing identification of the use of a tool for different goals. That's what I believe, anyway.
Thank you my name is Felix Moruno from the University of Texas. So I found very interesting your talks, and they were very stimulating. So I am very naive in this field, but I was wondering if there is any external stimuli that can mimic your methods. If that can, I'm not sure if, for example, reading every day is a very low stimulus compared to your protocols.
Well, you're probably familiar, or you may not be, but I mentioned as non-invasive brain stimulation in my slide multisensory stimulation, because there is work from Li Hui Zai's group and Ed Boyden and others using sensory gated stimulation, sort of tactile or visual, or actually even better, tactile and visual and auditory all together at specific frequencies, having, at least in mice, rather nice effects, and an ongoing pivotal study in human, in patients with Alzheimer's disease, and the company called Cognito that is aiming to entrain gamma activity, but through the sensory stimulation, not even directly targeted. The results in animal models are quite interesting. The human studies will wait and see what comes out. But one of the challenging things there is that the appeal of these techniques is the targeting of specific brain networks that map onto specific symptoms. That sensory stimulation assumes a leap, that you can specific sensory networks get modulated in such a way that association cortices and downstream effects of it will show a benefit. We'll wait and see. But I think it's a good point that one may be able to get a similar type of modulation of brain activity, not just directly to the brain, assuming that there is no added benefit of being more targeted. I believe there is, but it's an experimental question.
If I can ask one more question. So do you anticipate that this method cannot be as beneficial in a certain population of patients with AD? For example, it was discussed in the previous panel about the APOE4 homozygous.
Well, I think Giacomo can expand on it, but there is work showing that the effects of this modulation, because of network roles of APOE, are different in different APOE subtypes, both from his group, from our group, and
as well, right?
Yeah.
So we independently reached to the same evidence that there is quite a strong signal that the plasticity, induction of plasticity, is different in patients according to the APOE genotype. So we may actually predict, and this is something that we are testing in our current trial, that APOE genotype may have a role in determining the response to rTMS. We don't know in which direction, honestly. Yeah. It's pretty unclear, but we are expecting something happening there. Yeah.
The same has been found with BDNF subtypes, and it has different effects. So my guess is that we'll get to a point where pharmacology and genetic and baseline characterization of the neurophysiologic state needs to be taken into consideration to even conceptualize what kind of neuromodulatory approaches to take. I think we're at time from what they've told me, so maybe we'll stop it there. Thank you so much for the organizers for the neuromodulation session.